Hello and happy Teach Me Tuesday. My name is Lisa. I'm an experienced NICU nurse and a NICU nurse educator here to give you another NICU nursing topic broken down, and it is our third part of our NEC series during NEC Awareness Month. If you have not watched parts 1 and 2, I urge you to pause me now and go back and watch parts 1 and 2. It will be helpful because we're kind of culminating it all together today with diagnosis and treatment. So as you know, we have been talking about the risk factors for NEC, the key signs and symptoms that nurses should know, and now it's time to talk about what the diagnosis is, how we could anticipate what the next steps would be as NICU nurses, what kind of imaging we would think about. We're going to talk a little bit about labs. We're going to walk through kind of the difference in the surgeries and what we do if the baby just has medical NEC. So let's dive into that. So one thing I think is so important is to understand that for a baby to be diagnosed with true NEC, they do have to have pneumatosis on their x-ray. However, we like to say a baby has NEC, or we put them on bowel rest when they get kind of this big belly, kind of like the picture in the upper left corner where the bowel wall's inflamed. Maybe they feel a little sick, they're not digesting their food really well. However, they don't have pneumatosis, they don't have profound acidosis, they don't have issues with DIC. This is going to be more of medical NEC. And even before that, you might hear terms like swelly belly, or they have big belly, or they're not tolerating their feeds. All of those things, that doesn't mean that your baby has NEC, your patient has NEC. It could be some warning signs for sure, as we talked about during signs and symptoms. However, it's probably not that actual diagnosis. And you may say to yourself, hey, we held feeds for 48 hours. Why didn't that end up as a diagnosis for my patient? And we're going to talk about why. But with surgical NEC, you're always going to see that as a diagnosis. That involves intestinal perforation, necrosis, or deep deterioration in the gut where we feel like we need to go in and do some exploratory surgery to figure out what's going on. Medical NEC can become surgical NEC. Absolutely, that can happen. But just to think that it doesn't, they are two different things, and we're going to go into a little bit more of what that is. And that all started from Bell's criteria. If you have been following me on social media this week, I have been talking about the NAN podcast that came out. And again, I urge you to go listen to it. The podcast name is NANcast, NANNCAST. And this week on Saturday, because of NEC Awareness Day, it came out and it's all about NEC. And what they're talking about in there is that this criteria came out so long ago that it may not actually be the best way to diagnose NEC. It is the best way that we classify it right now, but changes could be coming. So I just wanted to plug that because it was so good. And I have like nothing to do with them, but it is so good. What I'm talking about is this idea of stage 1. And we also came up with modified Bell's criteria. I think it was in like 2000. So they have updated it a little bit. Don't quote me on the 2000. I can't remember exactly what year it was, but where it used to just be 1, 2, and 3, and now we're 1A and B, 2A and B, and 3A and B. But 1A, 1B is really this idea of that swelly belly, that mild distension, some residuals, some vomiting, some bloody stools, that we don't have actual pneumatosis. And so we might put the baby on gut rest, make them NPO for 48 to 72 hours. Maybe we do that 48 hours of a rule out sepsis where we get a blood culture and a CBC. We put them on some antibiotics just to make sure we're clear. But we don't actually say, hey, you have NEC. Because in order to say this baby has necrotizing enterocolitis, we really need to get to that stage 2, which is pneumatosis on an x-ray. And in that case, you're going to end up similar idea, NPO, probably 7 to 10 days, antibiotics, decompression, start some TPN. When we start to see more signs such as metabolic acidosis, thrombocytopenia, we may be NPO longer, we may change our antibiotics. We may have surgery come in for a surgical consult to watch the x-rays with us to see kind of, hey, what's going on with the gas pattern? Do we see any areas where there's nothing moving through to indicate there might be some dead bowel in there? Stage 2 really is probably what we're seeing the most. I worked in a level 3 NICU, 3B, for the first 13 years of my career. We did not do surgeries there except for ROP and PDA. So if a baby progressed to needing surgery, they left our NICU and went to a children's hospital. I didn't see a lot of that, right? I didn't see past this, but I saw a lot of kind of stage 2, watching, Replogle, etc. The next unit I worked on, we did these surgeries, and we had it was a full level 4. I had all the surgeries except for cracking of the chest. So we had a surgery team in there. We would watch them look at the x-rays. I watched the surgeon measure the space on the x-ray to see how dilated the bowel was getting on the x-ray. It was so fascinating. I encourage you, not just in this situation, whenever there is an expert or specialist nearby, get in there and listen. You will learn so much. This was probably, I don't know, 5 years ago. It wasn't even that long ago. So go in and listen. I took care of a baby once that had very clear stage 2A, and that is that the baby was actually a 35-weeker, had always received mom's own milk, breast milk. However, mom had had pretty severe preeclampsia and had kind of an urgent C-section for decelerations. So that was probably the biggest risk factor. The baby got to full feeds. They were 35 weekers, so we were increasing the feeds a little faster than we went on a 25 weeker. And on day 7, started having spikes in their blood sugar to the point where the blood sugar was over 200. AC blood sugars on a breastfeeding baby over 200 is way too high and abnormal. At the 8 p.m. care, the diaper was changed and there was blood in the diaper. X-rays were done and there was pneumatosis. The baby never really got sicker than that. She actually did really well, went NPO, got a Replogle, and started antibiotics and got better. But that's that idea of kind of that 2A, 2B. 3A, 3B, 3A is like you're getting real sick. We are 1-to-1. We're definitely intubated. We're definitely working on how can we help this baby through this DIC. And then 3B is when we have this perforation or we see gas in the portal venous system. 3A, you may end up with surgery as kind of an exploratory surgery to see what's going on. So I think 3A and 3B is when you're seeing those surgeries, and that's going to be your surgical NEC. So with medical NEC, as we mentioned, these babies are going to need bowel rest. They're going to be NPO for 7 to 10 days. Their Replogle is going to have low intermittent suction. They're going to be on triple antibiotics. That should say intermittent. I am seeing that right now live with you, even though I read these 1 million times. Low intermittent suction, where it goes on and off, on and off. They're going to be getting abdominal x-rays every 6 hours. It's one of my favorite questions to ask in sim when we're talking about NEC in our pre-brief. And I'll be like, how often do you think the baby's going to get x-rays? And people say like, oh, every day, every other day. And I'm like, no, every 6 hours until it stops changing or improves, which is usually for a minimum of 24 hours, but could be longer, just to make sure that we're not seeing anything going on there. Frequent labs. These babies require a lot of vigilance. So at the very least, you're probably going to only have 2 babies depending on how sick they are. And that baby I was speaking about that was 35 weeker, she never required any oxygen or anything. So she went on to a 2-baby team. And then by about day 3, when she had a PICC line and was NPO, she was back on a 3-baby team. So it really depends. I've been asked a lot about like, what do you do with your staffing assignments when this happens? In the moment that a baby is showing signs of medical NEC, it is going to be an intense change in what's going on. You're going to need access. You're going to need labs. You're going to need the Replogle. You're going to need the suction, all these x-rays. You're probably going to be 1-to-1. At the very least, someone's going to be taking care of your other babies for a period of time. So that's just something to think about, but you may not stay 1-to-1. Whereas if we have surgical NEC, if the baby's extremely unstable, you may start with a drain at the bedside. A drain at the bedside is extremely common if the baby has a spontaneous perforation. And I'm going to pause right here and remind you, we talked about this once before, but again, a spontaneous perforation in the first, 12 to, 84 hours, 96 hours of life is when they most likely are happening. A spontaneous perforation is not NEC. Necrotizing enterocolitis is when there is an infection and an inflammation that causes the bowel to inflame and die, right? That's what necrotizing means. A spontaneous perforation is when something happened in the gut and it perforated, whether that is from extra air in there, whether it's from something that happened, but it is not from NEC. So it is treated usually with a drain, and the drain usually comes out and the baby heals well. They may still get antibiotics. They are still going to get a Replogle, but it is different than this idea of NEC. However, a baby can have NEC with free air, like you're going to see in this x-ray here at the top. Do you see this free air kind of sitting here above the liver? And they have NEC and they need a drain because they are so unstable, we cannot get them to the OR. So that is kind of what's going on there, just kind of some things to remember, except for those babies that go and have the actual big surgery where they get bowel removed. This usually starts as exploratory, and then depending on what they see when they're in there, it's going to depend on how much bowel the baby loses, where they lose it from, if they need an ostomy. I can't tell you exactly what's going to happen. That's outside of my scope. I'm not a surgeon or a surgical NP. I have not been in there for the surgeries for this. I've just taken care of the baby before and after. But what I can tell you is that the surgeon often has an idea of what's going to happen before they go in, but they don't know for sure until they're in there and seeing what they're seeing. So just know you're going to find out when they come back what they're coming back with, and kind of decide what's happening. The surgeon, like I mentioned, maybe looking at it on x-ray and really saying like, okay, this, so if you look at this x-ray, as a reminder, this baby is prone. I know it says it there, but the baby is prone. So you see the gut over here and you see these areas. This is what they're measuring. They're like, how long is this loop going on in here? Over here where it looks like this fixed loop. Again, is that staying there? Is it getting bigger? Does that mean that there's dead bowel around it so the air isn't able to move through? That's what the surgeon's assessing when they come to the bedside. This, to my eyes, is pneumatosis along there, and so that also puts the baby at risk. Sitting there. So for us as NICU nurses, what are we doing when the baby comes back? We are going to be dealing with pain control, fluid balance, blood pressure, antibiotics, TPN, worsening infection. If your baby was in this 21 to 30 days of life, they didn't have a PICC line anymore, they're eventually going to need central line because they're going to be on antibiotics and TPN for an extended period of time while they're NPO. They may be getting dopamine, dobutamine, all those things. So PICC line placement may be going on. Make sure that you are watching for their pain control. This is not a time to be restrictive in our pain control. Remember, they just had a big surgery. We need to watch their eyes and nose. That includes what's coming out of their Replogle. You need to know what your policy is on your Replogle replacement because every unit is different. And so me telling you what to do is not always going to be exactly what you do, but know what your Replogle replacement is. And then we take care of our ostomy. And to be honest, I think one of the hardest things in the NICU is to get these things to stay on the baby, especially the smaller the baby, and you just don't have the real estate to really get that wafer on. So I encourage you to use your wound care team. I just noticed how much the picture of that baby looks like a baby, and it's a doll, and it like really looks like a baby. My daughters have very lifelike babies. But you have this idea of getting that ostomy covered and to stay on. I know as a nurse, it's like if that thing stays on for your whole shift, you're like, thank you, right? And then once you get something that works really well, drawing it out for someone else or making a pattern at the bedside, this is going to help your babies and help you, but I always encourage you to use the wound care team. I know we're hesitant because they don't take care of NICU babies as much, but they know everything about the products that go on skin and how they're going to best stay on. So call your wound care team and get your families helping you, because some babies go home with the ostomy. We usually try to reconnect before discharge. We know that, but just in case we don't, teach them. They can be helpful to you. They can be helpful in, helping take care of the baby and keeping them calm while you're doing it, but get them in there. Remember, the parents should be the primary caregiver, so get them in there with you. So what are the long-term outcomes after a baby has NEC, whether it's medical or surgical? Obviously, if it's surgical NEC, they could have short bowel syndrome and reabsorption issues depending on how much of the bowel was resected. And I've heard things where people are like, oh my gosh, this baby had like 20 centimeters out. Sometimes it's not so much the distance, but where. And if the baby loses the ileocecal valve, they tend to do worse than babies that just lose a lot of intestines in other locations. So that's because that valve is pretty important in their digestion and getting everything moved down toward their rectum. So just something to think about. I am a asker, right? So when the surgeon comes and says, oh, this is what happens, I want to be like, oh, what do you see as kind of some long-term outcomes here? And that's important for you to share with their families. They may have feeding difficulties, digestion issues. They may be on long-term TPN. They may need specialty formulas. They may need to go back in for adhesions, or if they go home with their ostomy, to get their ostomy reclosed. This is going to be a medically complex baby most likely, so it can be strained on the families, and we just need to make sure we set them up for success by having those interdisciplinary conversations. So throughout parts 1 and 2, we haven't really talked about parent education. I wanted to wrap up our part 3 and just talking about that. And I've been asked this a lot, especially in simulation and in talking with new nurses, is when do we tell parents about this? And if you look at the NEC Society, they talk about this a lot too, this idea, if you watch any of the videos from the parents there, where they say, I didn't even know that NEC was a risk factor. And I agree. And I also think we do this with apnea of prematurity, and then parents see the first apnea and are like, what's going on? I do think it's our job as NICU nurses to let parents know what may happen. And that's not on the first day when the mom's still on MAG or the dad is like, what is happening? I'm taking care of the mom and the baby and all these things. It is, as the baby is starting to feed, or we're doing oral immune therapy, and we say, has anyone told you why we do this oral immune therapy? And they're like, oh no. And you say, so digestion begins in the mouth, and we want to help promote a healthy gut for your baby. And so we do this oral immune therapy where we get it into the mouth so they can start building that healthy microbiome from your breast milk. This is why we're doing skin to skin, so they can get on your skin and get your flora, and that will help them have a normal, help it there with their microbiome. You see what I'm doing when I'm looking at their assessment. I'm looking at their belly every single time. Babies are at risk for something called necrotizing enterocolitis. These are the things we are doing to help set them up for success. What you can do as the parent to help set them up for success is skin to skin care, being here every day, participating in rounds, pumping your milk, asking questions, telling us if you notice a change in your baby. I talk about all this multiple times, and then if something does happen, or maybe we have to hold feeds because there's been a large emesis or a green emesis, or the belly's looking big, then they've had this understanding and it doesn't feel as overwhelming. But when we're doing that, we need to avoid our medical jargon. We need to keep them informed. We need to use words that they understand. I always say, like, have you ever taken probiotics? Or has anyone ever talked to you about your gut microbiome? Or have you heard that buzzword out there? What does that mean to you? Okay, well, this is how we're helping your baby with that. So if a baby does have NEC or showing signs of NEC, acknowledging that this is scary and overwhelming, but still involving them in care, getting the baby out to kangaroo, offer hope, but be realistic about what could happen. If the baby's going to surgery, help them be prepared for when the baby comes back about what we may be doing. If this baby was on CPAP, doing well on getting full enteral feeds, has surgical NEC, is going to probably come back intubated. Remind them of what the breathing tube is going to look like. Remind them that their baby may have a wound. Well, is going to have a wound, whether that's just a surgical incision or an ostomy. And then how can we get them connected to somebody in social work or chaplain to come to the bedside and be with them? And then what is follow-up going to look like? Again, the NEC Society is a great place. I do think that all of those organizations can sometimes feel overwhelming to parents. So just reminding them to give themselves boundaries of what they really can take in from these organizations. But making sure that they have follow-up post-discharge, and just being there to answer their questions and connecting them with the doctor or the surgeon as needed to answer further questions. So as we wrap up our 3 NEC for NICU nurses, Teach Me Tuesdays, well, it was a Tuesday, a Friday, and a Tuesday. It's just a little recap of all the things that we've talked about. We've talked about distension and bloody stools and instability. We've talked about the Bell staging, our treatment options. But what I implore you to do, and if you are following me on social media, which I encourage you to do on TikTok or Instagram, is to really remember that you and the parent are often going to be the person that notices those small, subtle changes, such as a change in their state. They're more lethargic, they're crying more, a change in their color, a change in their behavior, a change in the frequency and duration and severity of their apnea and bradycardia. And those little changes are what's going to help us catch these early and often, and hopefully prevent surgical NEC. Thank you for following along for these 3 weeks. These 3 Teach Me Tuesdays. They were all 20 minutes, so this is a full hour, but next, a big one for us in the NICU. I hope you learned something, and please let me know if you have any questions.